Good evening, ladies and gentlemen. A warm welcome to the Digital Healthscape webinar, an event organized as part of the 10-year anniversary celebrations of IIM Udaipur. I'm Prakash, faculty member in the marketing area and co-chair of the Center for Healthcare at IIM Udaipur, along with my colleague, Professor Veda Purnappan. The Center for Healthcare at IIM Udaipur looks at healthcare from a management lens and acts as a platform for research as well as conversations and collaborations among academics, practitioners, and policymakers. Today's event, co-organized by the Center for Healthcare and the Center of Excellence in Digital Enterprises Management, aims to throw light on how digital technologies are helping bridge the gaps in healthcare faced by our country. In today's event, we will consider the challenges in health sector, both at the macro level and at the micro level. At the macro level, we will see how digital technologies can power solutions for health system level issues. We will also hear panelists talk about how they are leveraging digital to provide solutions through their healthcare ventures at a micro level. To start things off, I invite Professor Janat Shah, the founding director of IIM Udaipur, to welcome the participants.
Thank you, Prakash. Good evening. And on behalf of IIM Udaipur community, I have a great pleasure in welcoming you to this event webinar on digital healthscape. As a part of this, I'm going to use this to talk a little bit about our journey, because we have completed 10 years, and talk a little bit about, the way we look at our future, and somewhere the way we look at, webinar like this in our journey. We started our journey about 10 years back, but from beginning, we said, let's build this institution in a very different way. Right from beginning, we said, can we build this institution as a research-focused institution, where we should be globally recognized for the research which we do, which would make an impact on society. And simultaneously, we said, can we look at our own, whole education system as a transformation journey for all our students. Here we are, where we have completed 10 years. And I think, partly when we talk to, our alumni, when we talk to our faculty colleagues, we feel that we have reached at least at some stage. We are proud in terms of where we are today. Just to give a sense of certain external indicators through which the world looks at us. For example, we had said we should be known globally for our high quality research work. So one of the indicators we track is, UT Dallas ranking, where we look at publication in the top 24 journals. And it's a proud feeling today that for the last 4 years, we've been consistently in top 4 within country on the research front. Similarly, one of the indicator globally people look at is the Financial Times ranking for a master's in management. And it's a proud feeling that for the last 3 consecutive years, there are only 3 institutions which have been part of this ranking in the top 100. Those 3 institutions are Ahmedabad, Bangalore, and Udaipur. These are 3 institutions which have been consistently there in this ranking. We believe all this is because we've been focused on building a high quality culture at the institution. And one of the important decision we took actually before COVID was to look at how the whole landscape is going to change because of the way digital technology was transferring the way we do everything in life and the way we manage businesses. So we set up a center for digital enterprise with the whole idea saying, can we look at through this lens in terms of the way business are going to manage? And we also started a 1-year MBA in the specific area. And it's we feel proud that somewhere we started this journey much before the COVID. Similarly, we had started the Center for Healthcare much before COVID. And I think now today, it's interesting to see how the digital has transformed the way world is touching every part, including the healthcare. I want to briefly touch upon the way we look at future. At our institute, we went through a Vision 2030 exercise. We said we've done well so far, but I think we have a long way to go. And as a part of Vision 2030, we have again decided to focus primarily on, 3 areas. One, which is saying that's research. We need to, stay focused on the research and again, make sure we're seen as a thought leader in this space, including digital. Second, we said we need to, the way we look at our student transformation journey, can we ensure that we create great opportunities for our students, through our transformation learning? And as an institute, can we build a distinct identity in the times to come? And this is we have a very ambitious set of goals. And just to, illustrate with this one goal, where we have decided that by 2030, we want to be in this UT Dallas global top 100 list. Why is this ambitious? Today, there's not a single institute from India in that list. So we're saying we want to be, known for our research as well as student transformation journey. Today's event is something special for us because, 2 centers have come together and put together the event where we want to understand. So in general, as a part of, celebrating a decade, we wanted to touch upon a whole lot of issues where digital is going to impact, business and society. I think there's a need to reimagine every part of business and society in terms of how digital is going to impact. Earlier, we did a series where we looked at, impact of digital in a business landscape in general. And today, we're going to look at specifically how digital is going to impact the healthcare space. And like all of you, I'm very, keenly looking forward to hear the exciting set of speakers we have today. Mr. Kiran, Professor Vijay Chandru, Mr. Jagdeep, and Mr. Jaydev. Specifically, Professor Vijay Chandru also happens to be a good personal friend. So like all of you, I'm looking forward to this exciting conversation today. And what we're hoping is this will be a start-off conversation where we'll kick off. I'm sure we'll have a lot of ideas, which those conversations will continue forward in the time to come. So again, thank you for joining us in this webinar. And I look forward to the exciting conversation in the next 1.5 hours. Over to you, Prakash.
Thank you very much, Professor Shah. It is now my privilege to introduce Mr. Kiran Anandampillai, our keynote speaker. Kiran is currently the advisor technology at the National Health Authority. He supports the National Health Authority to deliver digital public goods under India's two large digital health initiatives, the Aishman Bharath Digital Mission and the PMJAY. Kiran is a telecom engineer by training and was a founding member of OnMobile, where he helped build it to become a public company. He was a volunteer with UIDAI for the Aadhar program and is currently a volunteer with the iSpirit Foundation, where he works on the health stack. He dedicates his time to driving impact in healthcare. He is the founder and CEO of iDrishti, which delivers high-quality eye care from a district capital to the village level. iDrishti currently manages 12 eye hospitals across Karnataka, India. Welcome, Kiran. I look forward to your perspectives on ABDM and how it has the potential to help the country leapfrog in healthcare.
Hi, can you hear me?
Yes, we can.
Yeah, my apologies for my lighting. Unfortunately, I wasn't able to get to a location with better lighting, so sorry for that. So would you like me to quickly start on my part of the talk right now?
Yes, please.
Yes, thanks so much, Prakash.
Thank
so
you.
I will request screen sharing. Yeah, it's enabled. Thank you so much. Hello, everyone. Good evening, and welcome to this session where what I'll try to do is I'll try to use the next 15-20 minutes to kind of give you a quick overview of what is this initiative by the government that some of you might be familiar with, which is called the Aishman Bharath Digital Mission. Now, many of you might know this is actually an initiative by the National Health Authority, but fundamentally was launched by the Prime Minister first in August 2020 and then nationally later last year. And the idea here is to provide what we call as digital building blocks for healthcare. So to understand what a digital building blocks are or what public goods, digital public goods are, the example I will use is say that of Aadhar or UPI. So if you think of Aadhar, today you can think of Aadhar as essentially an identity and an authentication system that can be used in any domain. It can be used, in the financial domain, it can be used in the healthcare domain, in the telecom domain, and so on. Similarly, UPI is a digital public good for the financial domain. So what would be the digital public goods in healthcare that can actually make a difference to healthcare? And that's really what the Aishman Bharat mission is really about. To understand this a little better, let us also take a look at where is India going specifically in terms of its data privacy laws. Many of you might be aware that India recently passed the data protection bill, was actually tabled in the parliament. The joint parliamentary committee report is out, and essentially it has two concepts. So anybody who is in healthcare essentially will have to also abide by these laws, because there is the construct that if I am holding any health data as a hospital, then I have to offer certain rights on that to the patient who's called the data principal. So the data fiduciary would be the hospital, the data principal would be the patient, and there is no construct of ownership. Nobody says, even though the doctor wrote the prescription, we don't talk about who owns that prescription. Because the doctor can claim ownership, so can the patient. Instead, all it says is, if you are holding that information with personal information, what rights will you offer to the patient? So there is a construct of consent that's built in very deeply into the law, which says, hey, before you can do anything with the data, you need to get the consent of the patient for many different things. But there is also a way by which digital consent can be obtained. And that's one of the key things where India is making a difference. And there's also something called a data protection authority that's coming to oversee these consent managers. Now, what we decided to do while the bill was coming was to make sure that the architecture and the systems we were building with these building blocks would completely align with this. So to make it easier for you to understand, it means that if a hospital decided to make their software compliant to what the Aishman Bharat Digital Mission is doing, they would automatically be compliant to the law of the upcoming law of the data privacy thing. Now let's understand this a little better. Now, many of you may know that healthcare is already going digital in many areas. So if you got a COVID test done last year, you likely got an SMS on your phone, you went to some lab's website, you probably saw the report to say whether you were either positive or negative. And so that really means that the patient, the lab is already sharing information with you digitally. And so the challenge that we have today is that while labs and hospitals are willing to share health information with you digitally, these are not becoming part of your long-term information. So today, if I ask you to go find the COVID report, you might find it hard. So, and also this PDF or the document that you see is in different formats. So, it's human readable and interpretable, but it's not as easily machine readable and interpretable. And so what we are trying to do really, one of the areas that the mission is trying to do is saying, if you are giving a report digitally, can you start by linking that report with what we are calling as a PHR address? PHR stands for personal health record address. So it's like, and we'll talk a bit more about it. We used to call it the health ID. We now call it a ABHA address. But fundamentally, the idea is that anybody who wants to have their digital reports can get themselves an ID, and then any healthcare institution can link records against that ID. And two, when they actually share that record, they would share it in a machine readable standardized format, which makes it quite easy. Now, what kind of information can actually be linked to your health record or your PHR address? So we said that we would focus on what is already digital or easy to be digitized and what is most commonly found within your file. So what do you see? If you open a patient file, what will you see? Typically, you will see diagnostic reports. In most cases, you will see that they're already printed reports, which means it got generated on a computer. So why can it not be shared digitally with you and become part of your record? So whether it is an imaging report like an X-ray, CT scan, or an MRI, or pathology reports, those are all possible. Other things are discharge summary. So if you have an inpatient episode, typically a discharge summary is a medical legal requirement. So those would happen. What is likely to be handwritten today is mostly OP consultation notes and prescriptions. And so there will be a certain amount of time it will take for that to change to become digital, but the standards that we have built allow for that. And of course, immunization records, including your COVID records, are actually part of this story. Now, I talked about the fact that the linking happens with an ABHA address or a PHR address. We used to call this the health ID a bit earlier. We're now calling it an ABHA, which stands for Aishman Bharath Health Account. And all you need to get one is basically just your name, date of birth, gender, and a mobile number. And for people without a phone, they can actually get it using an Aadhar. And that's the way the system works. And essentially how you get it, and people who are online, you can actually try this right now. You can actually go to healthid.abdm.gov.in and you can actually try to get your address from this. But many of you will really get it from an app. So if you have your Arogya Setu app, you can try creating this. You can open your Arogya Setu app and you can actually create your ABHA address, and it will also help you fetch health records as we kind of go forward. Paytm also does this. Eka Care does this. Many other apps. So similar to the UPI world today, where you don't think about which app you use when you pay a merchant. In the future, you will choose a PHR app and you'll be able to collect your health records from any healthcare institution that's participating in ABDM. Very similarly, we have something called assisted registration. So for people who don't have phones, hospitals will start issuing something that we call as an ABHA card so that they can actually get and collect their health records even without a phone. Now, what are we doing to get India started on this journey of personal health records for everyone? So the core idea that we're working on is this. Whenever a health facility creates a new health information, like a diagnostic report or a discharge summary, we want it to either notify or link. What does that mean? If, let us say, you did not share, let's say you still haven't got a PHR address, you haven't still created your ABHA, then we just want to notify you on your mobile number that, hey, you can actually just create an ABHA and get this record linked. But if you've already created an ABHA, we would like to automatically link it, right? So if you've created an ABHA and you share it with your health facility, we will actually automatically link that so that we can actually get going. And then you will be able to see those records on any of these apps. So that's the start point where you'll say, you will understand that, hey, I can collect my health records together, and then we'll come to sharing, where you can actually now start sharing it back with other healthcare providers you go to, other doctors that you go to, saying, I already have all my records here. I can share it with my consent so that you can see it and you can get a copy of it. So We expect this to happen. So a large number of India's healthcare providers have already expressed interest in participating in this program. So what you see on the market ready is organizations that have gone live on this architecture. And then we have several of the big brands and others who are doing integrations right now to kind of make this happen. And of course, there are several people who are kind of building PHR apps, and you're going to see several choices in the market for all of us to kind of do this. Now let's get into one more level of detail to kind of understand how does this PHR address actually help create these longitudinal records. Now, where really are your health records? Now, if you think about it, whenever a hospital says I've created a digital record, it's actually doing it with some software. These softwares are usually called health information management systems or laboratory information management systems. They're usually hosted or at the premises of that facility. Now, in our architecture, we only put a link, and this link that we put against your health information is actually held by a digital building block that's called the Health Information Exchange and Consent Manager. So if you look at who holds your PHR address and all the links, that is one of the digital building blocks that I'm talking about. So this digital building block is holding that information. It actually has absolutely no health data. There is no central repository. So this is not very different from what happens today on paper. If you go to a place and you have a healthcare interaction between you and a doctor, maybe you get a printed report, your doctor has the data, you have the data. It's quite similar in the digital world. Your software at the doctor's place has the data and you have a copy of the data, and there absolutely nobody else has a copy of the data unless you are willing to share a copy. And that's really what it hands. So your PHR address only has links and all of the records are held by the health facility, but you can get a copy and then you can start sharing it with your consent. So this is how the architecture looks like. So on the left side, you have anybody who's creating health information. That can be a health program like a mother and child program, a TB program of the government. It can be a private or a public hospital, a diagnostic center or a clinic. All the records are held by software that is being used by these facilities. So any software provider can actually participate. They integrate their systems with the building blocks that ABDM is doing, which includes the ABHA, the Health Information Exchange and Consent Manager, and you can view this on any PHR app, and anybody else who wants to have a copy can actually pull that information using consent. Now, one thing it's important to note is that not anybody can link information with your health record. If they want to link an information with your health record or with your PHR address, they need to be part of the health facility registry. So that's why we know that only trusted healthcare providers are really able to link records with your PHR address. And of course, if you have user generated data, like for example, if you have a scanned copy that you want to add to your health record, you can do it through your PHR app. And that's how the overall architecture works. Now, one thing to note, I said that we want to have structured data that is exchanged. But what we found when we started working with the ecosystem is that most people in India do not understand health data standards, whether it is a lab standard like LOINC or whether it is a clinical standard like SNOMED CT. Very, very few of the software players in our ecosystem are using these standards. So essentially, we have come up with a structure where you can start with attaching your existing PDFs, but within a year, you will have to move to using one of these standards. So all of the various players are essentially working on that. So that's how the whole process works. But this is very important. So if we want to do other things, like for example, we want to plot a trend. So I'll give you an example. I was talking to this company that works with a variety of labs, and they said that the lab names for one test, which is a cholesterol test, they have 52 variations of that name. So unless we actually adopt certain standards where every test uses a standard code, it's going to be very difficult for us to actually aggregate and anonymize data that will be available or useful to the ecosystem. So one part of ABDM, which I've spoken about, is for making sure we can help you access your own health data and then use it for your care. But the other part that ABDM also will do is it will create these aggregated data sets and also anonymized data sets, which are very important. Especially many of you might know that in radiology, one of the fastest areas where AI has been applied to help doctors has been actually in radiology. And all of those are data hungry spaces where large data sets are required. And one of the things that ABDM wants to do is to create these data sets that are available to the ecosystem for training and other purposes. Now, the second area that we are working on, and so far I have been talking mostly about exchange of health data, but we are actually working on three areas, exchange of health data being the lowest layer. The next layer that we're working on is what we call as interoperability for digital health services. Now, digital health services, the most common service we talk about is teleconsultations. Now, if you think about teleconsultations, many of the places where we want teleconsultations is actually on the second consultation, because you've gone seen a doctor and then you have a review or a follow-up, and that's the most common case. Now, the best case experience for a teleconsultation actually happens when both the doctor and the patient use the same app today, because you can create that integrated experience. But doctors are very not comfortable with promoting a particular app or a particular product to all their patients. Now, with UHI, what will happen is the doctor can choose any app they want. And in that app, they can set up how much they want for a teleconsultation, when are they available, and so on. And then you as a patient can use any app. You will be able to find the doctor by just putting their doctor ID. And you will be able to then say that, hey, I want to be able to book an appointment, make a consultation, send your health records, get prescriptions back, all through UHI. And UHI is not just for teleconsultations. It will also do things like finding your nearest ambulance, getting a pharmacy delivered home, and so on. So this is the other layer that we are working on. And so if you really look at what we call as the building blocks, we are working really on three building blocks. Two I have spoken about. The bottom layer is about exchange of health information, and that's really between providers and patients. We are also working on exchange of health information for the purpose of claims, which is for between payers and providers. So imagine that you had an inpatient episode. Today, it's actually quite very paper-based and very expensive for hospitals on the claim side. So we are looking to how we can actually bring a technology layer which brings in standards so that we can even introduce OPD claims in this ecosystem. And then, of course, we are working on an interoperable health layer. Now, how do organizations or anybody who's interested? So ABDM is open to everyone. So what I usually tell them is, hey, if you're either creating health data or you want access to health data, where do you get started? So we have created something that we call as the Abdm Sandbox. This is the place where you can come in, you can sign up, and essentially you can integrate your software with all these digital building blocks that I'm talking about and get benefit of what we are creating on the ecosystem. This is a slightly dated dashboard, but it shows you the level of interest that we are having. And we have all of the software, all of the stacks that are available for any startup, anybody who's building software for either hospitals, labs, or consumers to come in and participate. And we are already seeing excellent participation. We look at the participants from a lens of three groups. We have the public system. So anybody who is doing software in the government is one group for us. The large organized corporates, labs, and hospital chains are a second one. And anybody who's building software that they sell to small clinics and nursing homes is kind of a third group. And so these are the three groups which are participating. And I expect more and more over time that there will be significant interest and participation from the ecosystem. And just like in UPI, so to tell you the UPI story, the specifications, similar digital public goods, we actually did specifications in 2015. 2016 were the first implementations, and really 2018 is when it started gaining share. And today, UPI is a global phenomena in terms of what it has done. We hope that health will go through a similar journey. We are in the 2016-17 timeframe of the journey that we have seen in UPI. So with that, I'll kind of end my talk, and let's listen to what the other panelists have, and hopefully get into an interactive session.
Thank you very much. Thank you very much, Kiran. It was fantastic talk, great overview of the ABDM. Thanks for throwing light on that. At this stage, my colleague and co-chair of the Center for Healthcare, Professor Veda Ponnappan, will take us through the second part of today's events. Veda, over to you.
Thank you, Prakash. Welcome, everyone. We heard from Kiran on India's unique national digital health infrastructure. Kiran had brought out key features of the system, including techno-legal mechanisms for maintaining the health data, decentralized architecture where patients have full rights and privacy to their data, interoperable standards that can enable smooth healthcare data movement across various stakeholders, and a strong data governance through the health information exchange. Thank you, Kiran, for your insightful keynote address. We now move on to the next part of the event, the micro perspective on how different organizations are innovating and using digital technologies to provide unique healthcare solutions in the preventive, promotive, and curative space. It's my pleasure to introduce our panelists for the day, Professor Vijay Chandru, Mr. Jagdeep Gambhir, and Mr. Jaydev Verma. Let me first introduce Professor Vijay Chandru. Vijay, a PhD from MIT in Operations Research, taught at Purdue and at IISc. He is a fellow of the Academics of Science and Engineering and a National Distinguished Technologist. An executive advisor to Art Park at IISc and an adjunct professor at IISc and BITS Pilani, Vijay leads the technology workstream at Lancet Commission on reimagining India's health system. As an entrepreneur, Vijay led Strand Life Sciences as executive chairman. A winner of National MCIT Award for ICT Innovation, President's Medal of Informs, and a technology pioneer of the World Economic Forum, Vijay was named among 50 pioneers of change by India Today in 2008. Vijay serves on the Karnataka Vision Groups for Biotechnology and Science and Technology and on the board of Karnataka State Council for Science and Technology. It's a privilege to have you with us, Vijay. Welcome.
Thank you, Vida. Oh, sorry.
Thank you. Thank you, Vijay. I will take this opportunity to introduce our other panelists as well, and then I will come back to you, Vijay.
Sure.
Let me introduce also Mr. Jagdeep Gambhir. Jagdeep is the founder and chief executive officer of Karma Primary Healthcare. With the vision of solving the healthcare accessibility problem in rural India, Jagdeep founded this tech-enabled health startup in 2014, which now operates over 25 rural telemedicine clinics and multiple public health partnership projects. Starting out as a technology analyst at Goldman Sachs, Jagdeep developed a deep inclination towards healthcare. Prior to Karma, Jagdeep was a senior program manager at the Population Foundation of India. He was also worked with Innovators in Health, where he started a tuberculosis treatment program in rural Bihar. Jagdeep is an alumnus of Indian School of Business, Hyderabad, and National Institute of Technology, Surathkal. Welcome, Jagdeep. Our third panelist for the day is Mr. Jaydev Verma. Jaydev is the head of product at Ancora Health and is based in the Netherlands. After 12 years in a range of global product leadership roles at the Dutch health tech multinational Philips, Jaydev chose to make a career shift last year and joined the leadership team of Ancora Health, a digital therapeutics startup that's also based in Netherlands and founded by ex-Philips executives. Through a holistic approach scaled through digitally enabled programs across the prevention continuum, Ancora seeks to address the growing epidemic of lifestyle-based diseases and aims to add 5 million healthy years to society by 2030. As head of product, Jaydev leads the platform innovation, product management, and UX design for the company. Jaydev lives in Utrecht with his wife, Sandhya. Welcome, Jaydev. I now request Vijay to share his experience with Strand Life Science, the company he co-founded. Vijay, can you please take us through your journey of being an academic to an entrepreneur, from lab to market, especially focused on healthcare research? Over to you.
Yeah, thank you, Veda. And hello, Janat and Prakash. And, first of all, congratulations. I guess it's your 10th anniversary. And, that's always an important landmark. So great to be here and to be sharing this special day. I think, you heard a fantastic technology presentation by Kiran. Anandampillai. Of course, I have also been working closely with others at iSpirit and on various things. But I think I'll use these few minutes to really talk about the Strand journey, because I think we are switching from macro to micro. Basically, I'm a computer scientist and by training, and what we saw in the 90s was an extraordinary sort of acceleration in what we called the fourth paradigm of science, data-driven science. And in particular, we saw biology going through this acceleration of experimental data coming out through high throughput experimentation. And it looked like they really needed better tools to be able to analyze that data and make sense of it. And this was the Human Genome Project. It was also high density microarrays and various instrumentation that was leading to this data explosion. And so that's how Strand began. We were a bunch of computer scientists trained in machine learning, data science, and we said we will start building the MATLAB for the biological sciences, for the life sciences. And so Strand began as an early bioinformatics company driven by computer science. And it was also historically the first time in India that professors had stepped out and started a company. So IISc had to figure out all the rules to allow that to happen. And that was an exciting part of that early journey. Essentially, we established we were the guinea pigs. We basically, all the rules that were set up for us to do this essentially set up the whole faculty entrepreneurship agenda at IISc. And now, of course, there have been 20, 30 other companies that have come out of it, and hundreds of companies that students and so on have generated. So it's an exciting time. But so again, getting back to Strand, for 10 years then, we just built the tools that were used to annotate the human genome. And from all kinds of experimental data. And the exciting part about doing that was that we were early. We were also probably unique in the sense that it was a company founded by computer scientists that had come into the life sciences. So we were intellectual poachers in some ways, and I guess physicists and electrical engineers tend to be intellectual poachers anyway. So we sort of fit that mold. And we built those tools, and they actually became kind of the gold standard. We white labeled what we were building because we needed to reach a global market. And we used instrumentation companies like Agilent and Illumina and so on to actually reach the markets. And so these were branded by them as Gene Spring and so on. And it actually, in some sense, we were able to reach about 30% of the global market through that. I mean, very few people know this, but there was a complex scientific software products that were actually making a mark in the world, and we were, the tools that we've built have now about 30,000 citations in literature and so on. So we were helping that agenda for 10 years. And then around 2010 or so, we started seeing that all this advance in genomics and so on was starting to make a dent into clinical practice. And so the healthcare pivot for Strand started becoming clear that, we had spent 10 years in building all these tools. And now there was an opportunity to have direct impact into healthcare. And so we had to, from a business school perspective, this was a major pivot, right? You're a software company, essentially, and And now you need to build labs, you need to build outreach to the health infrastructure of the country, and you need to learn the whole sort of sales side of doing diagnostic tests, advanced diagnostic tests. We were really in the high complexity tests. We were not doing the basic cholesterol and biochemistry kind of tests. We were doing sequencing of tumors to be able to advise on targeted therapies for cancers. We were doing diagnosis of rare genetic disorders, where cases that had foxed neurologists and geneticists around the country and so on. So very, very exciting. I think, so we've actually had sort of two journeys, and we sometimes call it Strand 1.0 and 2.0. And then, we really, something even more exciting happened. I think, not so long ago, sometime last year, Reliance approached us and said that they would like Strand to become part of the Reliance group. And so, they've of course acquired majority shareholding in Strand. And now we are part of an infrastructure that is actually going to leverage in many ways what Kiran Anandampillai just spoke about. And, the ABDM is a really interesting, I think historically significant idea, because it's building a techno-legal infrastructure, right? And it's a publicly built techno-legal infrastructure, which then is going to impose and, essentially regulate, how health IT develops in this country. And of course, we will be on the other side at Strand, working within the Reliance framework and, building on top of the geo infrastructure and various things that, of course, Reliance has put together. And so it looks very exciting, that we're going to now be able to leverage this whole digital vision for healthcare in India and actually become a part of that. So I'll stop there and be happy to take up in the discussions. Thank you.
Thank you, Vijay. Thank you, Vijay. So thanks for sharing that exciting pioneering journey from being an academic to getting into the industry, and especially with Strand with 1.0, 2.0, and now going further with making use of ABDM. We hope to hear more from you on how you envision that ABDM is going to help the healthcare technologists. So at this point, I'd probably request Jagdeep to come in and share his exciting journey with Karma Primary Healthcare. So using technology to reach the rural hinterland, Karma has provided the last mile connectivity to deliver high quality primary healthcare services to the masses. So can you here share with us your experience, Jagdeep?
Sure. Thanks, Professor Veda. Thanks for inviting me, and all best wishes to IIM Udaipur on its 10th anniversary. So I'm going to talk a bit about what we do at Karma and why we do at Karma what we do. A bit about our operating model as well as our learnings over the last few years of kind of running, digital health enterprise in private rural sector. Right. Before I start, a few disclaimers I think that are required. I'm not a doctor, so this is not a preaching event, right? I mean, we are all learning together, and I'm also not a professor, so I think speaking for 8 minutes continuously does not come naturally to me, but I'll try to make it insightful, and share as much as possible. I'm sure all of us already know, especially in a post-COVID world, primary healthcare system and access to healthcare systems, in India, have challenges of access in rural areas. there is data to suggest that, even with so much of infrastructure and, services and effort by the government, a large majority of the people still seek care from a private provider. And given the acute shortage of doctors in rural India, most of the time this private provider is an informal and unqualified provider, which ends up, so people end up paying for healthcare, but it is also probably not efficient, right? There is no data, there is obviously no prescription, right? And there is, ethical concerns as well, right? And we therefore at Karma kind of looked at how do you provide access, using a digital platform to the rural and semi-urban parts of India, largely actually through the rural areas, right? So, and again, the idea of providing doctors as well as providing doctors to each village probably and specialist doctors will not be possible because of the shortage of doctors. So, one has to go a digital way, right, into that. So we are a nurse-assisted telemedicine platform, right, in which, technology for us is an enabler and not the end to what we do. We operate nurse-assisted clinics in rural India. We have about 25 of them in 4 states in the country, in which we build a clinic. It's a physical clinic, and the nurse then facilitates a video consultation between a patient and a doctor. The clinic also provides diagnostic services, pharmacy, along with this, right? So why do we keep a nurse, right? I think, people tend to ask a question that, you can just have an app, right? Or a website. Why do we need an app? But again, one has to be clear on the context and where we are operating. And I think, we are, if you look at our customer or consumer, which is in rural India, right? I think not many people have access to smartphones. And even if I think you look at telemedicine and doing a consultation, having a qualified medical professional on the other end increases the ability for the doctor to do consultations better. So we have a nurse, which is facilitating a video consultation. If the doctor is, wants to check up any vitals, let's say a blood pressure or a diabetes, a glucose indicator, that can be possible. As well as another key element is that if it is a dialect in India again, we are talking about rural areas. We're not only talking about languages, right? We're also talking about the dialect, right? So, how do you kind of, and, health is a lot about trust and doctor-patient interaction. How do you bridge the dialect and the language gap? And I think, that's where having a more human interface, especially at care delivery, is important. So that's largely what we do at Karma, right? Which is kind of a more nurse-assisted model. In a post-COVID world, we also now have a direct-to-patient access, right? So people can also, use our mobile app, and an audio, consultation mechanism, that is also there. We also leverage the capability that we have created to work a lot with the public health systems, right? So we work with many state governments, especially for supporting their COVID relief work, home-based isolation, programs for COVID, as well as some other, projects, that we do. So this is kind of also leveraging the technology backend. Now, what have we learned, right, by doing this, right, over the last, many years now, actually? I just wanted to kind of quickly highlight 2-3 points, right, which might be interesting. One is that when we look at health systems and, delivering care, right, and mostly curative care in our case, that we look at this. One is that assisted models are, I think, the way to go, or more hybrid models, actually, right, which is kind of a combination of a, of a physical facility plus a purely digital facility. A true case, that we kind of, looked at is that, as soon as the kind of unlock happened and our clinics kind of started, many people who were doing consultations, a lot of them actually shifted back to coming to our physical centers and seeking consultation, right? So that was, I think, one of the key things, right? Second thing, and I think when we look at, again, healthcare in rural India, is providing more comprehensive services, right? So, unlike in urban India, where you can actually seek different specialties because they are, nearby, or you can actually access them, people in rural India would want more of a single stop solution for most care. So, as a digital provider, can you have more comprehensive services available at a single place, whether it is for screening, and so on and so forth. That is something that we have learned. One key thing, and I think that's where ABDM comes in very naturally, is to kind of integrating and linking primary care to secondary and tertiary care. we refer about 10% of our patients, or in a typical world, we would refer 10% of our patients who will require secondary and tertiary care systems. Digitally right now we can't do that much, but having a more technology-enabled ecosystem will kind of enable that, right? So that's kind of the third learning. And lastly, I think while we are all talking about digital and healthcare, right? I think in especially care delivery, I think one has to also look at the human and the HR angle associated with that, right? Is the nurse trained to talk with compassion, right? Or is the doctor trained to talk with compassion? And you can do that on a digital platform as well. Those are the things, right, which sometimes people overlook because we tend to believe that technology will do everything for us, but I think that is something that we need to one of the things that we have learned, that while the technology is the same, if you have a good nurse, right, and a good set of people, certain centers do better, right, than certain else. So that's again has been our learning, that how do you create when we call hybrid, it is also hybrid with social skills plus digital. As we go along. So yeah, that's a bit of our journey and some of our learnings. Yeah, thank you.
Thank you, Jagdeep. Thanks for sharing that journey of having a technology-led solution, but at the same time looking at other human touch components of trust and empathy built into the Karma healthcare delivery system. Thank you very much. Can I now invite Jayadev to share your experience with Ancora Health, please?
Thank you, Veda, and hello, everyone. Many thanks to IIM Udaipur for inviting me on this momentous occasion, and all the very best to the institution to scale many more heights. It's been a riveting session so far, with previous speakers already offering very interesting perspectives and insights across very different dimensions. And for my segment, I think I'd like to focus on 3 points. First is the population health problem, and the one that we believe as Ancora that digital technologies can help to address. The second is the value of digital therapeutics in the context of this problem. And the third is Ancora's specific approach and where we hope to make a difference. Now, I'll just speak to the first part, and then I do have 2 slides that I can pull up. The first part, the problem itself is one that governments, regulatory bodies, health systems, taxpayers increasingly recognize, which is that lifestyle-linked diseases and disorders are not just a leading cause of death, but also have a debilitating impact on society in terms of subjective well-being, quality of life, workforce productivity, household disposable income. And the current healthcare system has been either unable or unwilling to define structural solutions to a problem that has developed into the primary population health challenge of our times. Now, around this dark cloud, the pandemic has delivered an unexpected silver lining, which is the boost it has given to digitally enabled healthcare services, both in the developed as well as developing markets around the world. And in this context, different healthcare services have different roles to play. And so I think that's where I can pull up my slide. You can see this, right?
Yes.
Yeah,
okay.
It's visible. Good.
Great, thank you. So traditional healthcare that you see on the bottom left continues to focus on what is pejoratively but accurately called sick care, and is linked to episodic interactions, high utilization costs, low scalability, and other pain points like travel and wait time that are in some cases unavoidable, but not in all cases. The second block that you see there are the telemedicine companies, or telehealth, or teleconsultation, as we heard earlier. They're already delivering a step up in terms of improving access to quality care, and people are indicating higher levels of comfort with the concept after experiencing the convenience during the pandemic. And that might be through reduced wait time, easy information sharing, as well as wider choice by not being limited to a specific catchment area. Now, the digital therapeutics is not placed higher because it is more important, but simply because it is intended to be able to scale to a wider section of the population. right? So the role played by digital therapeutics is a very different one. The only way to reverse the rising tide of lifestyle diseases is for people to adopt and practice healthy behaviors, which is easier said than done. The role of digital is to democratize that access and make that accessible at affordable price points that enable such offerings to scale with palpable impact. So the solutions that can demonstrate and deliver these improved health outcomes at scale will rise to the top. And that then goes into the regulatory aspect, and how do you then filter out the obvious noise from the actual solutions. And I think those are aspects that we do need to discuss, but which I will not touch upon right now. Ideally, such an offering does not run in parallel or as a silo, but as part of an existing care pathway. And a patient's healthcare practitioner or GP is either aware or supportive or even willing to monitor progress periodically, and the business case then needs to take that into account. Now, sort of going into the third aspect, which is what does then Ancora do? What we do is we offer programs to help reduce the risk of chronic disease through sustained lifestyle change, and by doing so seek to add healthy years to life. Our mission is to add 5 million healthy years to society by 2030, and with time and growth, this ambition too will hopefully keep expanding. How do we do this? We first conduct a holistic assessment of your health, which is the block that you see over here, block number 2. As you can see, typically the model that we work with is either through referrals from a general practitioner or through an employer. We're not really in a direct-to-consumer business. But the assessment of health itself can range from polygenic plus blood and urine biomarkers, behavioral health assessment, all the way down to a comprehensive questionnaire plus a remote biomarker kit that we can send for data collection to the comfort of your home, if your home is in the Netherlands for now. On an aside, with an increased interoperability and access to the longitudinal patient record that we heard Kiran Anandampillai speak of, enabled by the ABDM, the need to repeatedly collect such data can be reduced or avoided if we have access to a personal health record. So this is again a public good that has implications and ramifications well beyond just a particular market, but obviously I can see the value in India. The second aspect is, once we have the assessment, what we do is we define a user's health goals and schedule a moment to agree that they need to work on that health goal. And that handshake is quite important, because without that buy-in, it rarely works. The goal itself is broken down then into a series of micro habits, which are these colored blocks that you see in the center of the slide. And those are across 4 standard vectors: activity, nutrition, sleep, and stress. But these often need to be addressed in combination, where some may be dependent and others are independent variables. So through this approach, we can address a wide range of chronic condition risk factors across the prevention continuum through a combination of the same building blocks calibrated to individual users' health and behavioral profile. So the program itself is delivered digitally and leverages ongoing usage data from connected devices, could be your Fitbit, your scale, your Withings blood pressure monitor. But we also ask questions in the application and nudge users towards positive behaviors. But this is supported by human coaches. So very much back to the hybrid model that Jagdeep Gambhir was just referring to. It's that blended model is something that we subscribe to very strongly. We don't believe that digital alone is going to cut it, at least for now. And that is where you sort of draw that fine line between digital therapeutics and the rest of the wellness space, where you're not necessarily held to the same degree of accountability in terms of health outcomes. So in terms of the screen, and this is the last slide, you can see that the mobile app screens on the left are for the user. They contain daily actions and show their data from connected devices, allow them to chat with a coach or a healthcare practitioner. And the screen on the right is the healthcare monitoring platform that a health care practitioner or a coach can use to stratify the population under care and interact with them through chat, audio, or video. So, apart from easy access, which is important in these cases, and that's where digital plays a role, There are two dimensions that we need to focus on, which speak to the behavior change model that we follow. The first is motivation, and that varies per user or health condition, but is also based on the physical environment, past experiences with similar interventions, associated risk factors, comorbid conditions, as well as even the perceived success in delivering on expectations. So it's never a one size fits all. Hence, managing motivation is quite tricky, but super important. And the other aspect is the ability, or what we call the skill level, to make the changes that are suggested, which then requires that these changes are both manageable and measurable. And that's where the data capture piece comes into play. So in short, users who achieve a certain skill level and maintain it over a time are well set to move into a self-management phase with minimal oversight, while their data based on informed consent can still be made accessible to a healthcare practitioner or provider if required. So that pretty much brings me to the end of the segment that I was hoping to cover. I'll hand it back to Veda now, and happy to answer questions.
Thank you, Jaydev.
Yeah, I'm just gonna get off this.
May I now invite the other panelists to join us for a question and answer session. And in the meantime, I would also request audience to put in any questions that they may have to the panelists in the chat box, or sorry, in the Q&A box that you'll see it. Okay, thank you so much for all of you to join again. Let me start the start the panel discussion with a question for Kiran. Now, what I would be interested to understand first is to understand the scope of what we are aspiring here with ABDM in India, right? So this morning I was reading a news on GE Healthcare announcing its intention to introduce Edison digital health platform, a vendor agnostic hosting and data aggregation platform, and an integrated artificial intelligence engine in the US healthcare market. We see similar such health platforms being spoken about elsewhere. So, and these are from private players mostly. And this is where we would like to understand the scope of what India is trying to achieve here through ABDM, and how does it even compare to any other global solutions, or is there even any comparison?
Sure, thanks, Veda. And I think it's a little hard to compare, what has happened, say, in the Western markets. I can tell you that we are very, very behind compared to most of the developed markets in terms of health data. But our dynamics are very different. If you look at the drivers in, say, a market like the US, most of digital healthcare was driven by payers who said that, hey, if you want X or Y from me, then I would like data in some format. And if you look at social markets or people like UK or Europe, many parts of Europe, they were largely, most of care is anyway provided by the public health system. So it's technically the IT division of the public health kind of becomes the driver for many of it. India is unique in the sense that, our mix of private care, public care, and also the fact that there's a very large out of pocket, which means that the consumer has a lot of say. In fact, if you talk to Indian providers, you will find that they listen to consumers more than they listen to payers, simply because the payer influence in India is extremely low. Demanded in many ways a slightly different approach to how we would actually kind of try to take digitization to the healthcare to the Indian market. And two, also, we had to make sure that whatever we did aligned with the upcoming laws of India, which are quite different from either HIPAA or GDPR in many ways, right? So the choices in what I presented really kind of represent the approach that we have taken. So it has many of the learnings from the Western markets, but wherever there were existing standards, we have said that we will use FHIR, we will use LOINC, we'll use NOMAD CT. But in the Indian context, we have applied this whole construct of consent-based sharing, the construct of consent managers, the concept of data fiduciaries, and data principles, which is more aligned with our law in the overall architecture. We've also taken a very federated approach where we are saying that there will be no central repository and so on. So India is likely to be fairly unique in terms of what it is doing. In terms of ambition, I think I would like to step back many of the examples and what you see in the West, and including what you see from Ankor. For example, what I heard Jaydev present on Ankor is actually very much part of the vision of ABDM, because I can give an example where, for example, on the Aishman Bharath mission, we would want to make sure that we use, say, biomarkers to know who are the probable guys who might require, say, a cardiac intervention in the upcoming year, and then therefore see if there are ways to actually have preventive health measures which reduce the number of people that kind of come in. And all of that requires data flows, also financial incentives to kind of align. But truly, ABDM is still starting with what I call as the plumbing layer. We are still laying pipes. We are still trying to connect the thing, make sure everybody has a tap. But a lot of the use cases are only when the water flows. And sometimes we talk about hot water, boiling water, or flavored water, which is still kind of a bit far away for India, I would say. So I think I see the next couple of years still about very basic things, very simple use cases in the first 2 years, which essentially ensures a free flow of health data across ecosystem participants and people joining the network. And it's really, I think, a couple of years out before you'll start seeing some very interesting use cases on what data can enable for various stakeholders.
Thank you, Kiran. That was quite interesting. And you also spoke about how anonymized data can be used, which is collected through ABDM, for further research and other diagnostics. This is where I would like to bring in Vijay to understand how this anonymized data that can get generated through ABDM kind of a platform will help in high-end research. That's first part of the question. And especially you mentioned about how some of these genomics or high-end research will involve a lot of data. And my second part is, how do we see the data and insights, the insights and intelligence that gets generated through such research getting absorbed by practitioners? How do we take that and take it to the masses?
So let me take the first question up. I think your question was, how do you leverage anonymized data? Now, actually, the real issue is not anonymized data. I mean, I think we really don't need to know the name of the patient, right? What we need though is clinical data, right? We need to know metadata about the individual. And along with that, we need things like a genome sequence or a medical image, various sort of clinical sort of measurements, right? And it's when you put all this together that you get the power of biomarkers and actual advisories for treatment and the ability to recognize what would be the most effective way to deal with various health situations. And I think people get very worried about privacy. And so it's really good that ABDM is sort of going to take care of that layer, right? And I think, this is really not an issue, I think, from the point of view of being able to build, useful sort of solutions. I think I think it's going to be a very interesting situation. Clearly the world is moving towards NFTs for health data, and I think, but you'll also have to make it somewhat fungible to be able to also do the linkages and the integration, and essentially come out with intelligent sort of inferences. And so I think I really admire the way the ABDM has been, thought through and structured, and I think it's going to really be the takeoff, and I sincerely believe that this will, India will leapfrog in many ways in healthcare because of we are paying attention to the right kind of infrastructure, and remember the Western nations really struggle because they have legacy systems. I think if you were stuck with an epic electronic medical record system, God help you, right? Or for example, developing the health exchanges in the US was, I think it was the major focus of the Obama administration that made it possible, right? So I think we have the advantage, of course, here that we're starting with a legacy system that is not going to really be that challenging. And so I think I'm sorry, what was the second part of the question?
I was curious to understand, how do you use this research that can get generated, or the insights and information that you can get generated from this data that is going to be available,
right,
and take it to the masses?
Yeah. So I think the goal is really precision population health, right? And the question is, how do you get there, right? I think we are at a point now where we are doing precision health in specific sectors like oncology, is very rapidly evolving in that sector, and which is why a company like Strand actually initially focused on oncology, because I think the physicians there, the oncologists are reading about how precision medicine is making a big difference in the treatment of cancer patients. And so thought leaders at Tata Memorial, or or Actract, and now of course many of the corporate hospitals have some great oncologists. They're all sort of encouraging this use of biomarkers and the ability to profile in with high precision the type of cancer, and the type of treatments that can be used. For example, the immunologics and so on. Of course, they are expensive, and how this goes to population scale will essentially be a question of how we can make this affordable. And I think the advantage we have is scale. I think, and the advantage we have is exponential technologies that are actually bringing down the prices very quickly. Just like you have Moore's law, which has rapidly brought down sort of the cost of computation and data communication. I think we have laws in biology, we call it Flatley's law for genomics, and it's also doubling every 12 months, and the prices are coming down rapidly. They should have been even lower. There are a few problems of monopolies and oligopolies, and hopefully, competition comes in and drives the prices down. But really, $100, whole genome sequence is within sight, which means that you could be doing a lot of very interesting genomic tests at $15, $20, which then starts looking like it can scale, right? So I think this is we are just starting to see the real impact of the genomic revolution. Strand has already spent 20 years, on this, but I think the exciting stuff is really yet to come. Right? Thanks.
Thank you, Vijay. Yeah. So just taking on that question to Jagdeep, where we were discussing about scalability of these solutions, right? And given that Karma is giving that last mile connectivity, I would like to know from Jagdeep how technology is enabling you in this total game of scaling up and sustainability.
In terms of how technology enables us, right? So one is, we are, because it is telemedicine, right? The first input point is technology, right? So without technology, right, access or consultation itself won't happen, right? So that's kind of the base, right? But how do we actually look at, what is the additional benefit, right, that technology can provide, right, to an end consumer or a patient, right? And there are 2-3 things, right, that we can look at from a organizational point of view, right? So one is that, can you do more, with technology? Can you increase efficiency of the system, right? So again, in our example, there is a nurse which is facilitating consultation between a patient and a doctor on any given day, right? Because nurse can, let's say, see 15 patients, right? Can you use AI and other technology engines to increase the throughput, right, as they call it in operations? That can the nurse see 20 patients, 25 patients, right? So you're basically making the system efficient, thereby, commercial viability, sustainability, of the model increases, right? Similar, use cases will be there in supply chain, right? Can you actually be more efficient in procuring medicines, right? Can you actually, ensure that there is less stockouts, right? And less, expiry wastages, right, onto that. So that's, again, directly impacts, the bottom line, right, for the organization. B, can technology also increase more value-added services, right, and more services, to the customers, right? As Mr. Kiran was mentioning, right? If we can integrate, with a referral system, right, create a mechanism in which we can, digitally talk to a lab, digitally talk to a hospital, right? I mean, you're bringing in a completely different, radical experience, right, which otherwise is not possible in a non-digital world, right? And that is only possible, because of technology, right? And same thing, right? And you can do more services, right? Provided digitally to a rural context, who otherwise actually will have, significant difficulties in accessing these, care because of the distance, right? So, what I'm trying to say is that yes, the base itself is telemedicine, right? So that's kind of a given, but I think the key innovation will actually happen on the other add-ons, right? That technology can give it. I hope that answers your question, but yeah, that's
Sure. Thanks, Jagdeep. So one of the other key challenges that India today is facing is this problem of NCDs, right? Such as cardiovascular diseases or diabetic. And management of such chronic lifestyle diseases does not just mean that you're taking medication, but also making those lifestyle changes and changing your behaviors and patterns, which seems to be the most challenging part in handling these diseases. So my next question then is to Jaydev, in how does digital help you to cross this cultural barriers and behavioral inertia to start uptaking these preventive health solutions or guidance that you provide through Ancora kind of apps?
Yeah, I think the digital probably doesn't help you in terms of, so there is a localization element which is extremely important, which is the reason why Ancora is not in India as of now. So that's going to be extremely important. They need to be relevant. As I said in my, when I spoke, there is no one size fits all. What digital does is it reduces, the barriers to adoption and access. So for example, especially in a market, and you heard Kiran Anandampillai speak about the fact that India has a very low payer penetration. It's mostly a self-pay market. And therefore, possibly employers might be a more viable channel. Employers of course, do have some kind of vested interest in ensuring that their employees are healthy, and there could be budgets or there could be incentives, I don't know, that drive healthier behaviors. And in such a case, of course, having a digital solution that can be deployed possibly with an escalation where required for people who actually manifest one or more chronic conditions becomes a much more viable option than, giving people access to, let's say, a clinic or just, giving them analog solutions that may or may not result in any measurable change. So, in short, I think it's a little difficult, Veda, to come up with a single answer. And I think it also depends on the stage of progression of the condition. If you're already managing an existing chronic condition, then you do need to have some kind of interaction with a healthcare practitioner at some level. And how do you build that engagement into the care pathway becomes critical. On a preventative scale, however, it is possible to do it possibly in an employer context. In healthcare, you can make the app accessible. You can reduce the amount of human requirement and thus make it more affordable. But typically, what we've seen, at least in Western markets, is that the self-pay space does not really exist and does not scale to that extent.
Thank you, Jaydev. Can I now zoom in back to Kiran to talk about the opportunities that ABDM is opening up to those who are interested in working in this cross domains of digital and healthcare? We have quite a lot of people in the audience who are interested in, our own students, including, who are interested in this space. So what are the kind of entrepreneurial opportunities that this is opening up?
Yeah, so I think this is a great time, if you're really in the health tech space, as I call it. And I think ABDM is kind of acting as a catalyst to this new ecosystem. I mean, you go back, we saw this in UPI too, while I think UPI was a public good, it wouldn't really have reached the scale that it did. Just to give you a parallel example, right? Before UPI, India had about 1 million people who were accepting credit or debit cards, million merchants. With UPI, essentially it's the ecosystem which got it to 10 million merchants, including your small pani puri wala who's now accepting it, right? And it's the same ecosystem, and it's the private entrepreneurship which drove more than millions of users to actually get used to the idea of paying through UPI. I think health is going to see similar opportunities, whether it is on the provider side, whether it's on the consumer side, or whether it's on the payer side. We see opportunities in all three for interesting innovations that will be enabled simply because now, hey, you have a way by which, say, you can access a patient history or share a health data or make it more interesting for a doctor or more interesting for a payer or more interesting for a consumer. And I think those use cases and those monetization opportunities is something that we are really looking at innovators to really come through. I work with a lot of young startups who come up with a variety of different ideas that they're experimenting in. Of course, some of them are pretty early to the market, but I think it's really a very interesting point for India. The thing I do worry about is India continues, the healthcare side of India still continues to be very, very underinvested in IT. If you look at the average IT budget in the West to the average IT budget that an Indian healthcare provider is willing to put on it, there's still a very large gap. The other part is also the fragmentation of our provider base. 95% of Indian healthcare providers tend to be single, individually owned practitioners, doctors, and clinics. And so I am not still sure, while I think large corporates and even medium-sized healthcare providers and labs we see doing significant IT investments now, we still don't see that yet picking up from the smaller providers who are unfortunately in India still the very large part of the base. So that's one side of it. I think I also think that adoption could be driven and will be driven through payer influence. While I've said that payer influence is low, it's not zero. And so you will see both, IRDA, the National Health Authority, the Aishman Bharath programs also drive it. And I think I see a lot more appetite today in the market for what I call as OPD insurance packages or OPD coverage, HMO kind of models starting to emerge even from the private sector. And all of them are also new innovations which use a combination of technology and a combination of, say, new approaches to payment to try to create changes in our healthcare ecosystem. And I think this is also going to be quite interesting for how India evolves. I just would like to answer one more query Veda I saw on the Q&A. I think somebody asked this question about when I share health data with consent, can I control what I share? The answer is absolutely yes. The way our consent architecture works is that you as a patient, and this is something that doctors don't like, but you as a patient can actually say, hey, I do not want to share certain portions of my health record with you as a provider. And yes, I think India is going to go through a lot of debate, in terms of whether this would be the right policy or the wrong policy, but that's where it is today.
Sure. Thank you, Kiran. So, you spoke about opportunities that exist for people who are interested in this space. I would be curious to understand, Jagdeep, so being a service provider in this space, how do you think adopting ABDM is going to help or make a difference to your patients?
Yeah, as I said, right, I think the first, the use case that we are really gunning for in the next 2 to 3 years is to integrate a referral pathway, right? That, can we actually quickly, in an early detection, early diagnosis manner, send a patient to a hospital when, a doctor, and on a telemedicine system understands and knows that this patient needs to, go to a tertiary care facility to get more tests done or get admitted, right? So that I think, will have massive impact as well on the patient as well as on the population health, right? So we essentially will be, the users of ABDM, right? I think, as Kiran mentioned, I think the building blocks, at least, the initial building blocks that we need are already there. Right. So we are kind of looking at, increasing and making, as I mentioned, healthcare more comprehensive, right? And I think that will have a phenomenal impact on, how we actually look at healthcare and make it more patient-centric, right? So stop thinking about tertiary, primary, secondary, right? And make healthcare more integrated, patient-centric. And I think that's where, we believe that, integrating with, so again, it's at the right time because, we are also, as a startup, just kind of getting into that place and the ecosystem is kind of, getting ready. So, we are, this actually is a lot of my funding pitch, right? That I actually went into our investors, right? And that's, I think, solves the problem of access in rural India in a very beautiful way, right? Because, can you actually make a privately financed primary care model successful? I think it's not been done many times, right? But if you think with ABDM, I think, there are, solutions which will then truly transform the industry.
Thank you, Jagdeep. You mentioned about patient-centric cares, right? And this is where I want to move on to Vijay to, in an earlier discussion you were mentioning as Commissioner for Lancet Technology stream, you were talking about how healthcare is going to become more patient-centric or individual-centric. Can you enlighten us more on how technology is going to change that?
Okay. So first of all, I should just mention that the Lancet Citizens Commission that I serve on has the charter to reimagine India's health systems for 2030 with a view towards how we can get to universal healthcare. And actually, Sharad Sharma of iSpirit, who works with Kiran closely, and I are together chairing the technology work stream there. And one of the things that we absolutely feel is that we have to be more citizen-centric in how we leverage technology. And so what we are trying to do, and in fact, if you go to the Lancet website, citizenshealth.in, you will see some glimpses of this. We're starting to work out vignettes, which are health journeys of patients, right? And so, for example, in one vignette, there is actually, an ASHA worker who comes and helps the patient actually select which of her health reports she should share with the physician before a telemedicine interaction with the physician, right? And uses the patient's biometrics to actually trigger the transfer of the health records or the opening of the health records for the physician to take a look before the telemedicine interaction. So, I think we just need to reimagine how all of these things may work. You can't, I know Jagdeep is absolutely right. You can't take the nurse the ASHA worker, the A&M out of the loop here. They have to be involved, right? And yet technology can enable all of this to happen in a very, very exciting way that finally does make it patient-centric. So I think I'm very hopeful that we're moving in the right direction. I think what we are getting into is an extraordinary ecosystem of like the financial sector is seeing, of APIs, and these APIs are going to help you do all kinds of interactions with the health system. But also, the APIs could be an AI app that actually looks at an X-ray or an ultrasound, which the ASHA worker is able to, because now you can have portable ultrasounds, or the nurse practitioner in a PHC is able to, do, fairly serious imaging, and then the AI takes over and puts in alerts, which then can actually go through a telemedicine link to a specialist who then gives advice and, maybe gets a mobile unit to the village to attend to this patient. So I think the reimagination is really important now, because, I think we need to break out of the challenges that we've had in our health systems. But finally, we also need money to flow into the system. But that seems like a harder ask because I think you have to fight big political battles to get that kind of funding in. But I think what's going to happen is that there's going to be a lot of entrepreneurial energy now released, and hopefully we will see an impact on our health systems, the same way that connectivity and I also worked on the computer, so I worked on the digital divide in the late 90s when it was a real challenge for people to be able to communicate, but today, of course, a smartphone, which is really what the computer had really been conceived of, has really achieved extraordinary connectivity across the nation. We're now at about 600 million smartphones, I think, and with Google Geo and so on coming in, I think we're going to see even higher levels of connectivity, and and with things like machine learning on the edge, you're actually going to have wearables and devices that can actually do extraordinary amount of computation right at the point of care. So I think lots of opportunities.
Yeah.
Right.
Thank you, Vijay. So you rightly put it. So we have the technology which is going to enable health sector, but at the same time, Jagdeep and Jaydev and Kiran have also pointed out the importance of human touch. And you had summarized it very well. Thank you very much. I would like to take this opportunity on behalf of Center for Healthcare and CDE to thank our panelists as well as our keynote speaker for joining us. I also take this opportunity to thank the audience for being part of this event and enriching our experience. Thank you, everyone. Have a great evening.
Thank you.
Thanks, Veda.
Thank you.
Bye-bye.